Hello, very good morning to one and all. This is me, I'm Dr. Jayanti Ghosh. So today I'll be going to speak on a topic that's avulsion and recent studies on it. Here again you can see that my name is written along with the second year PG notation. This was also a seminar which was asked by our HOD sir to present in our second year. So, dental avulsion is the complete displacement of a tooth from its socket in the alveolar bone, owing to trauma. That is because of any kind of sports injury, or while we are running or playing, there can be an injury which results in complete displacement of the tooth from its socket. The causes are, that is, as I said earlier, trauma from sports or accidents can cause teeth to fracture, loosen, or even knocked out. Management can be divided into management at site of injury, management in the dental office. At the site of injury, management can be done by reimplanting immediately, after rinsing with water. Before reimplanting, we rinse with water so that we remove any kind of germs present on the surface. When immediate reimplantation is not possible, place tooth in best available transport medium. Recently, an avulsed tooth preserving system called Tooth containing Hank's balance salt solution is available. It is a pH preserving fluid and trauma reducing suspension. It may be used in serious accidents that relegate reimplantation to secondary importance, and tooth is reimplanted when crisis is over. I've gathered it up from the Journal of Management of an Avulsed Primary Incisor, that is Endodontic Traumatology Journal. This is the diagram of Tooth, the emergency tooth preserving system. The tooth can be transported in the mouth by keeping the tooth inside the lip or the cheek if the patient is conscious. Management in the dental office, that is reimplantation of the tooth. If the tooth has been in any kind of physiological media, we have to reimplant it immediately as far as possible. And if the dry time is less than 15 minutes, reimplant it immediately only if the root apex is closed. Subsequently, after that, root canal therapy can be done. If root apex is open, reimplant the tooth and monitor the tooth for pulpal pathosis. This is a diagram for immediate reimplantation of the tooth directly into the socket, and there is a suction apparatus for withdrawing up of any excess amount of blood. If extraoral dry time is greater than 15 minutes, rinse with saline and reimplant only if the root apex is closed, because reimplanting the tooth with open apex can increase the risk of ankylosis, that is conjunction with the bone. Management of the root surface. We have to keep the tooth moist at all times by not touching the root surface, holding the tooth by the crown. Do not brush the root surface or remove the tip of the root. If the root appears clean, reimplant it as it is after rinsing with saline. If the root surface is contaminated, rinse with HBSS, that is Hank's balance salt solution, or saline. Use tap water if above is not available. Protocol for management of an avulsed tooth with open apex. We have to reimplant the tooth immediately at the site of incident. Reimplant, reposition, and we can verify the position of the tooth by an intraoral periapical radiograph. Then we can place flexible splints. Starting off with systemic antibiotics, giving any post-operative instructions, advising for anti-tetanus if required. Follow up in 7 to 10 days. If the tooth is from 15 minutes to 6 hours extraoral time stored in milk or HBSS, We have to soak in 1% doxycycline for 5 minutes or 50 mg capsule dissolved in 100 ml of saline. 15 to 20 minutes if the tooth is wet but non-physiologic media, that is water or saliva, then we have to change the transmute media to HBSS, Hank's balanced salt solution. If the time is from 0 to 60 extraoral dry storage, then also we have to change the media from tap water to HBSS. If greater than 60 minutes extraoral dry time is there, soak in citric acid for 3 minutes, rinse well and remove the PDL gently with scaler. And then we have to place in sodium fluoride for 20 minutes. If needed, we have to go for apexification, apexogenesis or root canal therapy. Protocol with an closed apex. We have to again reimplant at the site of injury, and we can also use physiologic saline or HBSS for 15 minutes to 6 hours. If the tooth had been wet for 15 to 20 minutes, but water or saliva, again we have to change the transport media to HBSS. If greater than 60 minutes, then we have to soak the tooth in citric acid for 1 minute, 3 minutes and rinse well for debriding and removing the excess PDL with water scaler. Then place sodium fluoride for 20 minutes and again verify the position of the tooth with intraoral periapical radiograph, placing flexible splint for 7 to 10 days, giving systemic antibiotic, post-op infections and anti-tetanus if required, and follow-up for 7 to 10 days. Root canal therapy will be required. Seek emergency treatment, it's all about time. Management of the socket. We should not curate the socket if clot is present. Use light irrigation with saline. Do not make a surgical flap unless bony fragments are there, because they will prevent reimplantation. If alveolar bone is collapsed, preventing reimplantation, carefully we should insert a blunt instrument to check that whether the socket is in position to the bone. Splinting, we have to use acid edge resin alone or with soft arch wire, or orthodontic brackets with massive arch wire. Suture only if alternative splinting methods are unavailable. Circumferential wire splints are contraindicated. Splints should remain in place for 7 to 10 days. However, if tooth demonstrates excess mobility, splint should be maintained until mobility reduces. This is the diagram. Bone fractures resulting in mobility require longer splinting periods, like 2 to 8 weeks. Home care instructions involve do not bite on splinted tooth, sound diet, maintenance of good oral hygiene. Alternative drug therapy, systemic antibiotics, chlorhexidine rinses and analgesics. If tetanus is required, then within 48 hours we have to give the prophylaxis. This was taken from textbook of pediatric dentistry by Nikhil Marwa. Endodontic treatment is we have to do root canal therapy where the tooth is open, apex, with less than 15 minutes extraoral dry time. Replant in order to revitalize the pulp. Recall every 3 to 4 weeks. Tooth with open apex and greater than 15 minutes extraoral dry time, we have to clean the canal and fill it with calcium hydroxide. Recall in 6 to 8 weeks. Then, if the tooth is having less than 15 with partially or completely closed apex, if less than 15 minutes extraoral dry time, then we have to remove the pulp 10 to 14 days after reimplantation, medicate the canal with calcium hydroxide, then obturate with gutta percha. This I have got it from Steinman R. et al. Article in Clinical Pediatric Dentistry, 1991. In greater than 15 minutes extraoral dry time with partially to closed apex, perform RCT intraorally or extraorally. If treated extraorally, avoid chemical or mechanical damage to the root surface. Avulsed permanent teeth require follow-up for 2 to 3 years. Complications is inflammatory resorption, replacement resorption, ankylosis and tooth submergence. Wound healing after implantation, that is 3 types of resorption will determine the wound healing. That is surface on the surface resorption, replacement, that is replacing the bone with some kind of other depositions, inflammatory root resorption. Replacement root resorption is also known as ankylosis, seen as the disappearance of periodontal ligament, latter followed by substitution of the bone. Inflammatory root resorption is seen as a bone-shaped cavity on the root surface with radiolucency affecting the lamina dura. Effects of diode laser radiation and fibroblast growth factor on PDL healing of reimplanted tooth. That is, on few number of experimental and control groups, fibroblast growth factor gel was applied on the root surface. Results showed that there were fewer resorptive areas in tooth applied with diode laser irradiation and fibroblast growth factor as compared to tooth in the control groups with no radiation or growth factors given. Then coconut water has a potential and soy for preserving the viability of PDL ligament cells. That is, study investigated the ability of pH adjusted coconut water and soy milk as a long-term storage media for PDL cells. That is, dog premolar teeth was taken for 24 hours having long shelf whole milk, SWM, long shell life skimmed milk and HBSS. The positive and 2 negative control groups were contributed to 0 minute, 30 minutes and 24-hour long term. In results, SSM, that is long shell life skimmed milk, showed lesser cell viability than HBSS and SWM. Then fluorescein diacetate as an agent to determine cell vitality of an extra-articular tooth in saline. FDA, that is fluorescein diacetate, provided an excellent method for determining PDL cell viability. Oral rehydration using fluid Gatorade and milk to find PDL viability was present in the journal presented by Harris et al. In Journal of Endodontics in 2004. Emdogaine was used for the treatment of replacement resorption presented in the journal by Philippi et al. Dental Traumatology 2002. Then propolis, a promising storage media for avulsion. Collagenase assay could be used for assessing the presence of saline for storage of avulsed tooth. So thank you. This is I come to the end of my presentation, and I hope you guys will like it. So if you have any doubt, do comment in my description box and comment in my comment box. I'll also include the link to my PDF PPT in my link box. Thank you and have a good day.